Laboratory evaluation of serum/plasma electrolytes and acid-base balance. Educational course with MCQ. By Tariq Mohammed Hammam. The electrolytes of most importance and abundance in the human body are cations: sodium, Na+, potassium, K+, calcium, Ca2+, magnesium, Mg2+, anions: chloride, Cl, bicarbonate, HCO3, phosphate, H2PO4, sodium, chloride, and bicarbonate exist as free ions. The other electrolytes listed exist in a balanced state between free ions and ions bound to proteins. The main functions of electrolytes are 1. The transmission of electrical impulses in neurons and muscles. Sodium, potassium, and calcium play major roles in this function. 2. Functioning as cofactors in chemical reactions that are catalyzed by enzymes. Magnesium, iron, calcium, zinc, potassium, and chloride all needed for important enzyme reactions. 3. The extracellular release of hormones from endocrine glands. Sodium, potassium play major roles in this secretion process. 4. Regulating intracellular and extracellular fluid volume. All electrolytes are involved to some extent in maintaining osmotic potentials, however, sodium plays the major role. 5. Regulation of the electrical potential, also known as membrane potential, between intracellular and extracellular fluid compartments. All electrolytes are involved in maintaining membrane potential to some extent, but sodium, potassium, and chloride play a major role in this function. 6. Blood coagulation. Calcium is the primary electrolyte in this process, which is why the calcium-binding compounds citrate and EDTA are used as anticoagulants for lab specimens. Sodium, Na+, is the most abundant extracellular cation. It comprises 90% of the extracellular fluid, blood, plasma, and interstitial fluid, solute concentration by mass, and is responsible for half of the osmotic pressure gradient between intracellular and extracellular fluid. Regulation of sodium balance. Normally, more than 99% of sodium is returned to the blood after being filtered by the nephron. Approximately 65% is reabsorbed in the proximal convoluted tubule, 25% is actively transported back into the blood from the descending limb of the loop of Henle, and about 5% is reabsorbed from the distal convoluted tubule by ANA+/Cl symporter. The remainder is reabsorbed from the collecting ducts. This extensive recycling and preservation of Na shows how essential Na is for the physiologic processes mentioned earlier. Consider what would happen to a cell if its extracellular fluid had a significantly different osmolality than the inside of the cell. If the osmolality of the extracellular fluid were too low, water would be drawn into cells. If it were too high, water would be drawn out of the cells. A cell may not have the energy to maintain its membrane integrity in these situations and may lyse and die due to the difference in osmotic potentials. This is why we use intravenous NaCl, at 0.9%, and not pure water when a patient needs to be immediately rehydrated. A NaCl solution of 0.9% has an osmolarity of 308 mmosmol/L, which matches that of normal plasma, and thus will not osmotically stress cells.
Hyponatremia is the term used to describe a lower than normal serum concentration of sodium. If a laboratory's normal range for serum sodium is 135 to 145 milliequivalents/L, a patient with a serum Na concentration below 135 milliequivalents/L is considered hyponatremic. Hyponatremia is most often associated with excess accumulation of water in the body. This causes sodium in the blood to be diluted, resulting in a lower concentration. A decrease in plasma Na concentration without excess water accumulation can be due to lower consumption of salt and excessive excretion of Na into the urine. Hyponatremia causes an increased movement of water into cells by osmosis. This can cause cells to swell. The swelling of red blood cells decreases their oxygen-carrying capacity and makes them too large to fit through capillaries. Swelling of neurons in the brain can result in brain damage or even death. Conditions associated with hyponatremia include the following. 1. Addison's disease affects the adrenal gland's ability to produce aldosterone. With reduced production of aldosterone, there will be a decrease in the reabsorption of Na and, as a consequence, a decreased plasma concentration of Na. 2. Syndrome of inappropriate antidiuretic hormone secretion, SIAD, is a condition in which there is a continuous secretion of antidiuretic hormone, ADH, even though the plasma osmolality is low. ADH is also known as AVP, arginine vasopressin. Under normal conditions, ADH causes water to be reabsorbed by the kidneys when the plasma osmolality is increased. When this hormone is continually secreted, water will continually be reabsorbed. This dilutes the extracellular fluid and results in a decrease in the serum Na concentration. ADH can be measured by the laboratory. Recently, copeptin, a precursor protein to ADH, was found to be a more stable and sensitive marker for ADH. Copeptin testing is now replacing ADH testing. 3. Cystic fibrosis results in the loss of Na and Cl as salt travels to the skin's surface with water, but is not reabsorbed. Normally, Na ions and chloride ions help move water to the surface of the skin and are then reabsorbed back into the body. Diuretics increase urine volume by promoting the excretion of salt and water from the kidneys. Loop diuretics prevent the reabsorption of sodium and chloride in the loop of Henle. Thiazide diuretics prevent reabsorption of sodium in the distal convoluted tubules. Diuretic use can lead to hyponatremia. Hyponatremia is a medical condition where the sodium level in the blood becomes too low. Normally, sodium helps regulate fluid balance, nerve signals, and muscle function in the body. Hyponatremia is diagnosed when the sodium level falls below 135 milliequivalents per liter. When sodium levels drop, excess water moves into body cells. This causes the cells to swell. Brain cells are especially sensitive, which can lead to dangerous brain swelling. Common symptoms include nausea, vomiting, headache, confusion, muscle cramps, fatigue, and weakness. As the condition becomes more severe, patients may experience seizures, loss of consciousness, or even coma. The infographic also highlights common causes of hyponatremia, including heart failure, kidney disease, and excessive fluid intake. The kidneys and heart play important roles in maintaining fluid and electrolyte balance. When this balance is disrupted, sodium levels can fall dangerously low. Treatment depends on the underlying cause and severity of the condition. Doctors may recommend fluid restriction, intravenous saline, medication adjustments, or treatment of the underlying disease. Because sodium correction must be done carefully, severe hyponatremia requires urgent medical attention. In summary, hyponatremia is a serious electrolyte imbalance caused by low sodium levels in the blood. Early recognition of symptoms and proper treatment can help prevent life-threatening complications.
Hyponatremia is a condition in which the sodium concentration in the blood becomes lower than normal. A normal serum sodium level ranges between 135 and 145 milliequivalents per liter. Hyponatremia is diagnosed when sodium levels fall below 135 milliequivalents per liter. Sodium is an essential electrolyte that helps regulate fluid balance, nerve signaling, and muscle function throughout the body. The infographic explains the pathophysiology of hyponatremia. When there is excess water in the body relative to sodium, or when sodium is lost excessively, the sodium concentration in the plasma becomes diluted. This lowers plasma osmolality, causing water to move into cells through osmosis. As water enters the cells, they begin to swell. Red blood cells may swell, reducing their ability to carry oxygen efficiently through the capillaries. More importantly, swelling of brain cells, or neurons, can lead to serious neurological complications, including brain damage, seizures, coma, or even death. The infographic lists several clinical manifestations of hyponatremia. Neurological symptoms include headache, nausea, vomiting, confusion, lethargy, seizures, and coma. General symptoms may include weakness, fatigue, muscle cramps, and nausea. Laboratory findings commonly show low serum sodium levels and decreased plasma osmolality. Urine sodium and urine osmolality may vary depending on the underlying cause. The infographic also highlights 4 important causes of hyponatremia. First is Addison's disease. In this condition, the adrenal glands produce insufficient aldosterone. Without enough aldosterone, the kidneys cannot properly reabsorb sodium, causing excessive sodium loss in the urine and lowering plasma sodium levels. Second is syndrome of inappropriate antidiuretic hormone secretion, also known as SIADH. In SIADH, excessive antidiuretic hormone causes the kidneys to continuously reabsorb water. This excess water dilutes the sodium concentration in the blood. Third is cystic fibrosis. In cystic fibrosis, defective chloride channels prevent proper reabsorption of sodium and chloride in sweat glands. As a result, sodium is lost through sweat, contributing to low plasma sodium levels. Fourth is diuretic use. Certain medications, especially loop diuretics and thiazide diuretics, increase sodium and water loss through the kidneys. This can lower sodium concentration in the bloodstream. The key message of the infographic is that hyponatremia usually reflects excess water relative to sodium. Proper evaluation should include assessment of fluid status, medications, and the underlying medical condition causing the imbalance. In summary, hyponatremia is a serious electrolyte disorder that can affect multiple organ systems, especially the brain. Early diagnosis and careful treatment are essential to prevent severe complications. Hyponatremia is a condition in which the sodium concentration in the blood becomes lower than normal. A normal serum sodium level ranges between 135 and 145 milliequivalents per liter. Hyponatremia is diagnosed when sodium levels fall below 135 milliequivalents per liter. Sodium is an essential electrolyte that helps regulate fluid balance, nerve signaling, and muscle function throughout the body. The infographic explains the pathophysiology of hyponatremia. When there is excess water in the body relative to sodium, or when sodium is lost excessively, the sodium concentration in the plasma becomes diluted. This lowers plasma osmolality, causing water to move into cells through osmosis. As water enters the cells, they begin to swell. Red blood cells may swell, reducing their ability to carry oxygen efficiently through the capillaries. More importantly, swelling of brain cells, or neurons, can lead to serious neurological complications, including brain damage, seizures, coma, or even death. The infographic lists several clinical manifestations of hyponatremia. Neurological symptoms include headache, nausea, vomiting, confusion, lethargy, seizures, and coma. General symptoms may include weakness, fatigue, muscle cramps, and nausea. Laboratory findings commonly show low serum sodium levels and decreased plasma osmolality. Urine sodium and urine osmolality may vary depending on the underlying cause. The infographic also highlights 4 important causes of hyponatremia. First is Addison's disease. In this condition, the adrenal glands produce insufficient aldosterone. Without enough aldosterone, the kidneys cannot properly reabsorb sodium, causing excessive sodium loss in the urine and lowering plasma sodium levels. Second is syndrome of inappropriate antidiuretic hormone secretion, also known as SIADH. In SIADH, excessive antidiuretic hormone causes the kidneys to continuously reabsorb water. This excess water dilutes the sodium concentration in the blood. Third is cystic fibrosis. In cystic fibrosis, defective chloride channels prevent proper reabsorption of sodium and chloride in sweat glands. As a result, sodium is lost through sweat, contributing to low plasma sodium levels. Fourth is diuretic use. Certain medications, especially loop diuretics and thiazide diuretics, increase sodium and water loss through the kidneys. This can lower sodium concentration in the bloodstream. The key message of the infographic is that hyponatremia usually reflects excess water relative to sodium. Proper evaluation should include assessment of fluid status, medications, and the underlying medical condition causing the imbalance. In summary, hyponatremia is a serious electrolyte disorder that can affect multiple organ systems, especially the brain. Early diagnosis and careful treatment are essential to prevent severe complications. Hypernatremia is a medical condition in which the sodium concentration in the blood becomes higher than normal. Normally, serum sodium levels range between 135 and 145 milliequivalents per liter. Hypernatremia is diagnosed when serum sodium rises above 145 milliequivalents per liter. This infographic explains the causes, pathophysiology, and clinical manifestations of hypernatremia. At the center of the infographic, water loss from the body is shown leading to concentrated plasma sodium levels. Hypernatremia usually occurs when there is a deficit of free water relative to sodium. As water is lost, sodium becomes more concentrated in the bloodstream. This increases plasma osmolality and causes water to move out of body cells, especially brain cells, resulting in cellular dehydration. The infographic lists several important clinical manifestations of hypernatremia. Common symptoms include thirst, dry mouth, weakness, irritability, restlessness, and confusion. More severe cases may cause muscle twitching, seizures, and coma. One major cause shown is primary hyperaldosteronism. In this condition, the adrenal cortex produces excessive aldosterone hormone. Aldosterone increases sodium reabsorption by the kidneys while promoting potassium and hydrogen ion loss. As more sodium is retained in the body, plasma sodium concentration rises. The key effect is sodium retention leading to increased plasma sodium levels. The second condition shown is diabetes insipidus. Diabetes insipidus causes excessive urination and loss of free water from the body. This occurs because of reduced secretion of antidiuretic hormone, also called ADH, or because the kidneys do not respond properly to ADH. Normally, ADH helps the kidneys reabsorb water. When ADH function is impaired, water reabsorption decreases, causing dehydration and concentrated plasma sodium. The infographic explains that diabetes insipidus is essentially the opposite of SIADH. In SIADH, ADH activity is excessive, causing water retention and low sodium levels. In diabetes insipidus, ADH activity is reduced, causing excessive water loss and high sodium levels. The third condition shown is Cushing's disease. Cushing's disease is caused by a pituitary tumor that stimulates excessive cortisol production. This can also increase aldosterone activity, resulting in greater sodium reabsorption by the kidneys. The final result is elevated plasma sodium concentration. The infographic emphasizes that hypernatremia commonly reflects dehydration or free water loss rather than simply excess sodium intake. Accurate diagnosis requires assessment of hydration status, kidney function, hormone balance, and underlying medical conditions. In summary, hypernatremia is a serious electrolyte imbalance characterized by elevated blood sodium levels due to water loss or excessive sodium retention. Early recognition and proper treatment are important to prevent neurological complications and restore fluid balance.
Potassium, K+. While sodium is the major extracellular cation, potassium, K+, is the major intracellular cation. In contrast to sodium, potassium has minimal effect on osmotic pressure as its concentration outside the cell is relatively low. Potassium ion regulation. Potassium intake, the distribution of potassium between cells and the extracellular fluid, and the excretion of potassium in the urine all factor into the body's overall K equilibrium. Potassium is freely filtered by the glomerulus, but 60 to 70% of the filtered K is reabsorbed in the proximal convoluted tubule along with water. About 25% of the remaining K is reabsorbed in the loop of Henle by the Na-K2Cl co-transporter pump. This Na-K2Cl co-transporter protein transports 1 Na, 1 K, and 2 Cl ions across the cell membrane, all in the same direction. The remainder of K, 5 to 15% of the filtered K, reaches the distal convoluted tubule. In the distal tubule, K reabsorption occurs via the Na+/K plus ATPase pump. Notably, the secretion of K and hydrogen ions by the ATPase is controlled by the hormone aldosterone. An increase in plasma K levels can stimulate the release of aldosterone directly from the adrenal cortex or through the renin-angiotensin-aldosterone mechanism. Aldosterone stimulates Na/K pumps embedded in the cell membranes of the distal convoluted tubules to pump Na out of the tubules and K into the tubules, where it is excreted with the urine. The net effect is that aldosterone promotes K excretion. Hypokalemia. Hypokalemia is the term used to describe a lower than normal serum concentration of K. If a laboratory's normal range for serum potassium is 3.5 to 5.5 milliequivalent/L, a patient with a serum K concentration below 3.5 milliequivalent/L is hypokalemic. Hypokalemia sometimes occurs due to an absolute reduction of K in the body. This could be due to starvation, vomiting, or diarrhea. Hypokalemia can also occur when K is shifted from extracellular fluid into cells. This can occur when diabetic patients use insulin. Insulin promotes glucose uptake in cells. As glucose is taken up, K is carried through the cell membrane, resulting in a decreased plasma K concentration. If K concentrations become too low, cells will hyperpolarize. This means that their resting membrane potential becomes too negative. For cells that depolarize or fire, like neurons and muscles, hyperpolarization means that a greater than normal stimulus will be required to initiate an action potential. Thus, hypokalemia causes cells to become less excitable. Prolonged hyperpolarization can lead to arrhythmia, irregular heartbeat, tachycardia, rapid heartbeat, and cardiac arrest. Potassium and pH. Acid-base disturbances affect the extracellular concentration of potassium. Changes in blood pH will cause potassium to shift into and out of cells. The plasma potassium concentration will rise by 0.6 milliequivalent/L for every 0.1 unit reduction of the extracellular pH. So as pH goes up, alkalosis, plasma potassium goes down, and vice versa. This happens in an effort to maintain electrical neutrality. As hydrogen ions move out of cells, potassium will move into cells to maintain electrical neutrality. Conditions associated with hypokalemia. Fanconi syndrome is a disease of the proximal convoluted tubules of the kidney. Normally, 60 to 70% of potassium is reabsorbed in the proximal tubule. In Fanconi syndrome, much less potassium is reabsorbed and is lost in the urine. Primary hyperaldosteronism is an excess production of aldosterone by the adrenal glands. This results in decreased potassium reabsorption, increased secretion, and a decreased plasma potassium concentration. Excessive use of thiazide diuretics. Thiazide diuretics promote the excretion of potassium into the urine, thus lowering the plasma concentration of potassium. Cushing's disease is caused by a non-cancerous pituitary tumor that stimulates the release of excessive levels of cortisol and aldosterone. Increased aldosterone results in increased potassium secretion and, thus, a reduced plasma potassium concentration. Syndrome of inappropriate antidiuretic hormone secretion, SIAD, is a condition in which there is a continual secretion of antidiuretic hormone even though the plasma osmolality is low. Under normal conditions, ADH causes water to be reabsorbed by the kidneys when the plasma osmolality is increased. When ADH is continually secreted, water will continually be reabsorbed, diluting the extracellular fluid and lowering plasma potassium concentration. Barter's syndrome is an autosomal recessive renal tubular disorder characterized by reduced function of ion channels and protein transporters in the thick ascending limb of the loop of Henle and/or the distal convoluted tubule. This leads to reduced reabsorption of potassium. Hypokalemia is a medical condition in which the potassium level in the blood becomes lower than normal. Normally, serum potassium levels range from 3.5 to 5.5 milliequivalents per liter. Hypokalemia is diagnosed when potassium levels fall below 3.5 milliequivalents per liter. Potassium, also known as K+, is an essential electrolyte that plays a critical role in muscle contractions, nerve signaling, and maintaining a normal heartbeat. The infographic explains that hypokalemia may occur due to an actual loss of potassium from the body or because potassium shifts from the bloodstream into cells. For example, insulin promotes glucose uptake into cells. As glucose enters cells, potassium also shifts inward, reducing potassium levels in the blood. The center section explains how low potassium affects body cells. Normally, cells maintain a resting electrical potential that allows nerves and muscles to function properly. When potassium levels become too low, cells become hyperpolarized, meaning their electrical membrane potential becomes more negative. As a result, cells become less excitable and require stronger stimulation to activate. This reduced excitability affects several organ systems. In the nervous system, symptoms may include weakness and decreased reflexes. In skeletal muscles, hypokalemia may cause muscle cramps, fatigue, and weakness. In the heart, low potassium can lead to dangerous rhythm disturbances, known as arrhythmias, rapid heartbeat, and in severe cases, cardiac arrest. The infographic also explains the relationship between potassium and blood pH. Acid-base disturbances can shift potassium into or out of cells. During acidosis, when blood becomes more acidic, hydrogen ions move into cells while potassium moves out of cells, temporarily increasing potassium levels in the blood. During alkalosis, when blood becomes more alkaline, hydrogen ions move out of cells while potassium shifts into cells, lowering blood potassium levels and contributing to hypokalemia. The infographic highlights several important conditions associated with hypokalemia. First is Fanconi syndrome. This kidney disorder affects the proximal tubules, reducing potassium reabsorption and causing excessive potassium loss through urine. Second is primary hyperaldosteronism. In this condition, excessive aldosterone hormone increases sodium retention, but also increases potassium secretion by the kidneys, lowering plasma potassium levels. Third is excessive use of thiazide diuretics. These medications increase urinary potassium loss, which can significantly reduce blood potassium concentration. Fourth is Cushing's disease. Pituitary abnormalities increase cortisol and aldosterone activity, leading to greater potassium excretion and lower potassium levels. Fifth is syndrome of inappropriate antidiuretic hormone secretion, also called SADH. In SADH, excess water retention dilutes blood electrolytes, contributing to lower potassium concentration. Finally, Bartter syndrome is a genetic kidney disorder that impairs sodium, potassium, and chloride reabsorption, causing potassium wasting through urine. The key message of this infographic is that hypokalemia decreases cellular excitability and can become life-threatening if severe. Because potassium is essential for proper heart and muscle function, identifying the underlying cause and treating it promptly is extremely important. In summary, hypokalemia is a serious electrolyte imbalance characterized by low blood potassium levels that can affect nerves, muscles, and especially the heart. Hyperkalemia. Hyperkalemia is the term used to describe a higher than normal serum concentration of potassium. Only 2% of total body potassium circulates in plasma. The majority of potassium is intracellular. Thus, cell injury will cause potassium to be released from cells and will raise the plasma potassium concentration. Hemolysis during blood collection is a frequent cause of pseudohyperkalemia in which the patient has normal potassium in vivo, but their specimen potassium is elevated due to a pre-analytical error, that is to say, cells were lysed during collection or transport. In vivo hemolysis can also occur and can raise blood potassium levels. For example, potassium from damaged muscle cells can occur during exercise, and burn victims experience hyperkalemia due to the destruction of cells. However, usually the body will compensate for the increased casein during in vivo hemolysis, and the excess potassium will be excreted. Thus, elevated levels are sometimes only seen acutely. Hyperkalemia raises the resting membrane potential of nerve cells, making it difficult to initiate the voltage necessary for depolarization. This can lead to paralysis, bradycardia, slow heartbeat, and heart failure. It is for this reason that potassium measurements are frequently ordered as a stat test. Conditions associated with hyperkalemia. Metabolic acidosis. As a response to metabolic acidosis, hydrogen ions move into the cells to raise the extracellular pH back toward normal levels. As noted earlier, potassium will move out of cells and counter to H+ ions and maintain electrical neutrality. Renal failure. High plasma potassium is the most significant and life-threatening consequence of renal failure. The combination of reduced filtration and reduced secretion causes plasma potassium levels to become highly elevated. Uncontrolled type I diabetes. Potassium is the most important electrolyte affected by diabetes. The frequency of hyperkalemia in diabetic patients is significantly higher than in the general population. A deficiency of insulin prevents the normal uptake of glucose into cells. In the absence of glucose for metabolic fuel, the liver metabolizes fatty acids to ketone bodies, acetoacetic acid, beta-hydroxybutyric acid, and acetone. This results in an increased H+ concentration, metabolic acidosis. In response, hydrogen ions move into the cells to raise the pH, and potassium shifts out of cells, increasing the plasma potassium concentration. Hemolytic anemia. Red blood cells contain 20 times more potassium than plasma. A rupture in the cell membrane of red blood cells releases potassium into the extracellular fluid and, in the short term, can result in a dramatic increase in the plasma concentration of potassium. Hyperkalemia is a medical condition in which the potassium concentration in the blood becomes higher than normal. Normally, serum potassium levels range between 3.5 and 5.5 milliequivalents per liter. Hyperkalemia is diagnosed when potassium levels rise above 5.5 milliequivalents per liter. Potassium, also known as K+, is an essential electrolyte that plays a major role in nerve signaling, muscle contraction, and maintaining a normal heartbeat. Only a small amount of the body's potassium circulates in the bloodstream. Most potassium is stored inside cells. Because of this, any condition that causes potassium to leave cells or prevents the kidneys from removing potassium can quickly increase blood potassium levels. The infographic explains 3 major mechanisms that lead to hyperkalemia. The first mechanism is cell injury or destruction. When cells are damaged, potassium stored inside the cells is released into the extracellular fluid and bloodstream. This may happen during severe trauma, burns, tissue injury, or muscle breakdown. The second mechanism is the movement or shift of potassium out of cells. Normally, potassium stays inside cells. However, certain metabolic changes can force potassium to move out into the blood, increasing plasma potassium concentration. The third mechanism is reduced kidney excretion. Healthy kidneys help remove excess potassium from the body through urine. When kidney function declines, potassium accumulates in the bloodstream, causing hyperkalemia. The infographic also explains the effects of hyperkalemia on the body. In the nervous system, symptoms may include muscle weakness, paralysis, and reduced reflexes. In the heart, hyperkalemia can interfere with electrical activity, causing dangerous rhythm abnormalities called arrhythmias. Patients may develop bradycardia, meaning an abnormally slow heartbeat, conduction abnormalities, or, in severe cases, cardiac arrest. At the cellular level, high potassium changes the resting membrane potential of cells, making electrical signaling abnormal and affecting muscle and nerve function. The infographic highlights an important laboratory concept called pseudohyperkalemia. Pseudohyperkalemia occurs when potassium appears falsely elevated because of problems during blood collection or transport. For example, Difficult blood draws, prolonged tourniquet use, rough handling, or destruction of red blood cells during sample collection can release potassium into the blood tube. In these cases, the patient's potassium level inside the body remains normal, but laboratory results appear falsely high. The infographic also describes true hyperkalemia caused by in vivo hemolysis. This happens when red blood cells break apart inside the body, releasing potassium into circulation. Examples include severe muscle injury, extensive burns, tissue trauma, rhabdomyolysis, or transfusion reactions. Several important medical conditions are associated with hyperkalemia. First is metabolic acidosis. In metabolic acidosis, hydrogen ions move into cells to help balance body pH. To maintain electrical neutrality, potassium moves out of cells and into the bloodstream, increasing plasma potassium levels. Second is renal failure. Kidney failure reduces the body's ability to remove potassium through urine. As potassium builds up, blood potassium levels rise and may become life-threatening. Third is uncontrolled type 1 diabetes. When insulin levels are low, glucose cannot enter cells properly. At the same time, potassium shifts out of cells. Metabolic acidosis caused by ketone production can further worsen hyperkalemia. Fourth is hemolytic anemia. When red blood cells break down, potassium stored inside the cells is released into the extracellular fluid, increasing blood potassium concentration. The key message of this infographic is that hyperkalemia can become a medical emergency, especially when it affects the heart. Doctors must carefully evaluate symptoms, medications, kidney function, and laboratory results to identify the underlying cause. In summary, hyperkalemia is a serious electrolyte imbalance characterized by elevated blood potassium levels caused by potassium shifts, kidney dysfunction, or cellular injury. Early recognition and prompt treatment are essential to prevent life-threatening complications. Chloride Cl. Chloride Cl is the principal extracellular anion. Along with sodium, it is a major contributor to maintaining the osmotic pressure gradient between intracellular and extracellular fluid. It also helps maintain blood volume and is essential for maintaining electrical neutrality by counterbalancing cations in the extracellular fluid. Chloride filtration. Chloride is freely filtered by the glomerulus. 99% of chloride is reabsorbed via active and passive processes within the nephron. Excretion and reabsorption of chloride largely follow that of sodium. When sodium is reabsorbed from the lumen of the proximal tubule by tubular epithelial cells, it is then transported to the interstitial fluid. Water will move with it. This helps create the countercurrent loop multiplier system in the loop of Henle. This concentration gradient is a key component of the nephron that allows the body to preserve water. Chloride shift. Inside red blood cells, carbonic acid, H2CO3, dissociates into HCO3 and H in a reaction catalyzed by carbonic anhydrase. H2CO3, carbonic anhydrase H++ HCO3. The hydrogen ions are buffered by combining with deoxyhemoglobin, which essentially traps the H inside the red blood cell. HCO3 is transported out of the red blood cell via anion transporter proteins. This leaves the interior of the cell with a net positive charge. Chloride ions are attracted by the opposite charge and, to maintain electrical neutrality, are transported into the red blood cell as HCO3 moves out. Thus, chloride plays an essential role in the chemistry of respiration. When blood reaches the lungs, deoxyhemoglobin combines with oxygen and is converted to oxyhemoglobin. H has a stronger bond with deoxyhemoglobin than with oxyhemoglobin, so as hemoglobin takes on oxygen, H ions are released within the red blood cell. HCO3 in the plasma will then diffuse into the red blood cell to balance the charge. As HCO3 enters, chloride exits. This is referred to as the chloride shift. Chloride, also known as Cl-, is the principal extracellular anion in the human body. Along with sodium, chloride plays an essential role in maintaining fluid balance, osmotic pressure, blood volume, and electrical neutrality within the body. This infographic explains the importance of chloride, how it is filtered and reabsorbed in the kidneys, and its critical role in respiration through a process called the chloride shift. Let's begin with the role of chloride in the body. Chloride is the major negatively charged ion found outside cells. It works closely with sodium to regulate the movement of water between body compartments. By helping maintain osmotic pressure, chloride supports proper hydration and blood pressure regulation. It also balances positively charged ions, called cations, helping maintain electrical neutrality in extracellular fluids. The next section explains chloride filtration in the kidneys. Chloride is freely filtered through the glomerulus, the filtering structure of the kidney. Approximately 99% of filtered chloride is reabsorbed as it moves through different parts of the nephron. Much of chloride reabsorption occurs alongside sodium reabsorption. In the proximal convoluted tubule, chloride and sodium are reabsorbed through both active and passive transport mechanisms. As sodium moves into surrounding tissues, water follows, helping preserve fluid balance. The infographic also highlights the loop of Henle, an important structure that creates a concentration gradient in the kidney. This concentration gradient allows the body to conserve water and maintain proper electrolyte balance. Further reabsorption occurs in the distal convoluted tubule and collecting duct, fine-tuning chloride and sodium levels according to the body's needs. The lower half of the infographic explains an important physiological process called the chloride shift. The chloride shift helps transport carbon dioxide from body tissues to the lungs while maintaining electrical balance in red blood cells. In systemic tissues, where carbon dioxide levels are high, carbon dioxide enters red blood cells. Inside the cell, carbon dioxide combines with water to form carbonic acid. This reaction is catalyzed by an enzyme called carbonic anhydrase. Carbonic acid quickly breaks down into hydrogen ions and bicarbonate ions. The hydrogen ions are buffered by deoxygenated hemoglobin, helping stabilize blood acidity. Meanwhile, bicarbonate leaves the red blood cell and enters the plasma. To maintain electrical neutrality, chloride ions move into the red blood cell. This exchange between bicarbonate and chloride is called the chloride shift. The infographic then shows what happens in the lungs. In the lungs, oxygen enters the blood and binds to hemoglobin. As oxygenation occurs, hydrogen ions are released. Bicarbonate moves back into the red blood cell while chloride exits. Hydrogen ions combine with bicarbonate to form carbonic acid once again. Carbonic acid is then converted into carbon dioxide and water. The carbon dioxide is exhaled through the lungs. This reverse chloride shift allows efficient carbon dioxide removal from the body. The key message of this infographic is that chloride is far more than a simple electrolyte. It plays a vital role in kidney function, fluid balance, acid-base regulation, and respiratory gas exchange. Without proper chloride balance, important body systems, including hydration, circulation, and breathing, cannot function normally. In summary, chloride is an essential electrolyte that supports osmotic balance, kidney filtration, and the transport of carbon dioxide between tissues and the lungs through the chloride shift mechanism. Hypochloremia and hyperchloremia. Hypochloremia. Hypochloremia is the term used to describe a lower than normal serum concentration of chloride. Generally speaking, the conditions that cause reduced Cl are the same as those that cause reduced Na. However, there is one notable exception: metabolic alkalosis. In metabolic alkalosis, high concentrations of HCO3 are produced. In response, chloride ions may be excreted by the kidneys to maintain electrical neutrality, and thus, a net loss of chloride, but not sodium, can occur. Chloride ions can be lost with the following conditions. 1. Kidney disease due to defective tubular reabsorption. 2. Sweating, vomiting, and diarrhea. 3. Gastric disorders that result in loss of stomach acid, HCl. 4. Any condition that results in a deficiency of aldosterone secretion, such as Addison's disease. 5. Thiazide and loop diuretics. 6. Bartter syndrome due to impaired salt reabsorption in the thick ascending loop of Henle. 7. Cystic fibrosis. Chloride imbalance refers to abnormal levels of chloride in the blood, an important electrolyte that helps regulate fluid balance, acid-base balance, and electrical neutrality in the body. This infographic explains two major chloride disorders: hypochloremia, meaning low serum chloride levels, and hyperchloremia, meaning high serum chloride levels. Let's begin with hypochloremia. Hypochloremia occurs when serum chloride levels become abnormally low. One important exception highlighted in the infographic is metabolic alkalosis. In metabolic alkalosis, bicarbonate levels in the blood become elevated. Because bicarbonate carries a negative charge, the kidneys excrete chloride to maintain electrical neutrality. As chloride is lost, serum chloride levels decrease. The infographic also highlights common causes related to fluid and acid depletion. Significant chloride loss can occur through excessive sweating, vomiting, diarrhea, and loss of stomach acid, also known as gastric hydrochloric acid or HCl. Vomiting is a particularly important cause because it removes hydrochloric acid from the stomach, reducing chloride stores in the body. Several medical conditions are also associated with hypochloremia. These include Addison's disease, cystic fibrosis, and the use of loop or thiazide diuretics. In Addison's disease, hormone deficiencies affect electrolyte balance and increase salt loss. In cystic fibrosis, abnormal chloride transport causes excessive chloride loss through sweat. Diuretic medications increase urinary salt excretion, often contributing to chloride depletion. Now let's look at hyperchloremia. Hyperchloremia occurs when serum chloride levels become abnormally high. One key mechanism shown is dehydration. When the body loses water, chloride becomes more concentrated in the bloodstream. Excessive dietary salt intake can also raise chloride levels, since chloride commonly enters the body together with sodium as sodium chloride, or table salt. Another cause is the administration of saline solutions. Intravenous saline contains chloride and may increase serum chloride levels when given in large amounts. The infographic highlights another important acid-base relationship called the metabolic acidosis exception. In metabolic acidosis, hydrogen ions increase and bicarbonate becomes consumed. To maintain electrical neutrality, the kidneys reabsorb chloride. This increase in chloride contributes to elevated serum chloride levels. Hormonal disorders can also play a role. Conditions such as Conn's disease, also called primary hyperaldosteronism, and Cushing's disease can increase aldosterone or cortisol activity. These hormonal changes alter kidney electrolyte handling and may contribute to elevated chloride levels. The key message of this infographic is that chloride imbalances are often linked to changes in hydration, kidney function, acid-base balance, hormones, and gastrointestinal losses. Understanding the underlying cause is essential for proper diagnosis and treatment. In summary, hypochloremia usually reflects chloride loss through fluids or metabolic alkalosis, while hyperchloremia often results from dehydration, saline administration, metabolic acidosis, or hormonal disorders. Maintaining normal chloride balance is important for healthy fluid regulation, acid-base stability, and overall body function. Calcium, Ca2+. Calcium, Ca2+, is an essential electrolyte routinely measured in clinical laboratories. Calcium is essential for muscle contractility. Calcium is also essential for blood clotting and serves as a cofactor in many enzymes. In the serum, about 40% of calcium is bound to protein. About 10% is found complex to salts and inorganic complexes. The remainder of serum calcium, about 50%, exists as free or ionized calcium. Most of the body's calcium is in bone. Less than 1% of the total body calcium is present in the blood and within cells. Like all electrolytes, calcium levels are highly regulated. Since bone is a large reservoir for calcium, the body has multiple mechanisms by which it can rapidly exchange or move calcium from bone to serum and vice versa. This exchange is regulated by several hormones. Parathyroid hormone, PTH, and vitamin D1, 25-OH vitamin D, are the most notable and the most commonly measured. When serum calcium is low, hypocalcemia is said to be present. This is often due to the absence or impaired function of PTH or impaired vitamin D synthesis. Chronic renal failure is also frequently associated with hypocalcemia due to decreased vitamin D synthesis. Severe hypocalcemia can lead to tetany, muscle spasms, and osteomalacia, softening of bone. Excess serum calcium, or hypercalcemia, can occur with increased ingestion of calcium salts, abnormal breakdown of bone, as occurs in cancers with bone metastasis, or as a result of endocrine disturbances. The most common cause of hypercalcemia is primary hyperparathyroidism. Severe hypercalcemia can result in cardiac arrhythmia. Ionized calcium. In the laboratory, calcium levels can be assessed using assays for total calcium or ionized calcium. Ionized calcium accounts for about half of the total serum calcium and is the physiologically active form of calcium. Low ionized calcium concentrations are often seen in renal disease, critically ill patients, or patients receiving rapid transfusion of citrate whole blood or blood products. Increased calcium concentrations are seen in primary hyperparathyroidism, PTH-producing tumors, or excess intake of vitamin D. Although ionized calcium represents the active fraction of calcium and is thus the most useful clinical test for serum calcium, it is not always easy to measure. The measurement of ionized calcium has traditionally been more expensive and less accurate and requires special handling of the sample. When measuring ionized calcium, the sample must be prevented from undergoing changes in the CO2 concentration. If the CO2 concentration increases, as can happen when samples sit too long, the pH of the sample will decrease. As pH decreases, H ions displace calcium ions from protein binding sites, and the amount of ionized calcium increases. Conversely, as blood pH increases, albumin and globulins become more negatively charged and bind more calcium. This causes the amount of ionized calcium to decrease. The total calcium in the sample does not change, but the ionized calcium can change depending on the pH. Welcome to this overview of bicarbonate, or HCO3 pathways and kidney regulation in acid-base homeostasis. This infographic explains how bicarbonate helps maintain the body's pH balance through interactions in the blood, cells, and kidneys. Bicarbonate is one of the body's most important buffer systems, helping regulate acidity and maintain normal physiological function. Section A: Cellular and Blood Panel. Let's begin with the cellular and blood panel on the left side of the infographic. Inside tissues, cells continuously produce carbon dioxide, or CO2, as a byproduct of metabolism. This CO2 diffuses out of the cells and enters the bloodstream. Within red blood cells, an enzyme called carbonic anhydrase rapidly converts carbon dioxide and water into carbonic acid, written as H2CO3. Carbonic acid is unstable and quickly dissociates into hydrogen ions, or H, and bicarbonate ions, HCO3. This process is critical because bicarbonate acts as a chemical buffer. When excess hydrogen ions accumulate, making the blood more acidic, bicarbonate can bind to them and help neutralize acidity. Notice the chloride ion exchange mechanism, also called the chloride shift. As bicarbonate leaves the red blood cell and enters the plasma, chloride ions move into the cell to maintain electrical neutrality. This continuous exchange allows the blood to efficiently transport carbon dioxide while preserving acid-base balance. Section B: Kidney Regulation Panel. Next, let's move to the kidney regulation panel on the right. The kidneys play a central role in controlling bicarbonate levels and maintaining pH stability. At the glomerulus, bicarbonate is filtered into the nephron. However, the body conserves most bicarbonate because it is essential for buffering acid. Approximately 75% of bicarbonate is reabsorbed in the proximal tubule, while the remaining amount is reabsorbed in other nephron segments, including the thick ascending limb. The kidneys respond differently depending on whether the body is experiencing acidosis or alkalosis. During acidosis, when hydrogen ion levels are high and the blood becomes too acidic, the kidneys increase bicarbonate reabsorption and generate additional bicarbonate. This helps neutralize excess acid and restore normal pH. In contrast, during alkalosis, when the blood becomes too alkaline, the kidneys reduce bicarbonate reabsorption and may excrete bicarbonate into the urine. This lowers bicarbonate concentration and helps rebalance pH. An important concept shown here is that bicarbonate is usually conserved, and significant bicarbonate loss in urine mainly occurs during alkalosis. Section C. Laboratory measurement. Now let's look at the laboratory measurement inset. In clinical medicine, bicarbonate levels are often calculated rather than directly measured. The bicarbonate concentration is derived using the Henderson-Hasselbalch equation, which relates pH, bicarbonate, and carbon dioxide levels. The infographic also highlights total carbon dioxide, or total CO2, which includes bicarbonate along with dissolved carbon dioxide and carbonic acid. Since partial pressure of carbon dioxide, or PCO2, is measured directly in blood gas testing, clinicians can estimate bicarbonate levels to evaluate acid-base disorders. Changes in PCO2 often reflect respiratory function. For example, elevated PCO2 may indicate hypoventilation, while decreased PCO2 may occur with hyperventilation. Section D. Key clinical insight. The historical note reminds us that bicarbonate and total CO2 are sometimes used interchangeably, but they are not exactly the same. Total CO2 represents a broader measurement that includes dissolved carbon dioxide and carbonic acid in addition to bicarbonate. Understanding this distinction is important when interpreting laboratory results. Conclusion. To summarize, bicarbonate is a major buffering molecule that protects the body from dangerous shifts in acidity. In the blood, bicarbonate helps neutralize hydrogen ions and transport carbon dioxide. In the kidneys, bicarbonate is carefully regulated through filtration, reabsorption, and excretion depending on the body's acid-base needs. Together, these systems maintain acid-base homeostasis, ensuring normal cellular and organ function. Welcome to this explanation of the infographic on the regulation of bicarbonate, or HCO3, by the kidney. Bicarbonate is one of the body's most important buffering molecules. It helps maintain the balance between acids and bases, ensuring that blood pH remains within a healthy range. In this infographic, we'll explore how the kidneys regulate bicarbonate through filtration, reabsorption, acid-base responses, and laboratory measurements. Section A. Filtration and reabsorption in the nephron. Let's begin with the top section of the infographic, which illustrates filtration and reabsorption in the nephron. The nephron is the functional unit of the kidney responsible for filtering blood and maintaining electrolyte and acid-base balance. The process begins in the glomerulus, where bicarbonate ions are freely filtered from the bloodstream into the nephron. However, bicarbonate is extremely valuable to the body and is rarely wasted. Nearly all filtered bicarbonate is reabsorbed back into circulation. In the proximal tubule, approximately 75% of filtered bicarbonate is reabsorbed. This makes it the major site for bicarbonate recovery. As the filtrate moves through the nephron, the thick ascending limb of the loop of Henle contributes additional bicarbonate reabsorption. Further downstream, the collecting duct fine-tunes bicarbonate handling. Around 5% may either be reabsorbed or excreted, depending on the body's acid-base needs. The key message here is that bicarbonate is almost completely reabsorbed under normal conditions and is typically excreted only when blood pH becomes too alkaline. Section B. Response to acidosis versus alkalosis. Now let's look at how the kidneys respond during acid-base disturbances. Acidosis. Low blood pH. In acidosis, blood becomes too acidic because hydrogen ion concentration increases. To correct this imbalance, the kidneys increase hydrogen ion secretion into the urine while conserving bicarbonate. As more hydrogen ions are excreted, more bicarbonate is reabsorbed back into the bloodstream. This response helps buffer excess acid and restore blood pH toward normal. In simple terms, high acidity leads to increased bicarbonate conservation. Alkalosis, high blood pH. In contrast, alkalosis occurs when the blood becomes too alkaline and hydrogen ion levels fall. During alkalosis, the kidneys reduce bicarbonate reabsorption and instead allow more bicarbonate to be excreted in urine. At the same time, hydrogen ion secretion decreases. This process lowers blood bicarbonate levels and helps return pH to a balanced state. In short, when pH is too high, the kidneys eliminate excess bicarbonate. Section C. Plasma bicarbonate and total CO2. Next, let's examine how bicarbonate is measured in clinical medicine. A blood sample contains several forms of carbon dioxide, including bicarbonate ions, dissolved carbon dioxide, and carbonic acid. Importantly, bicarbonate is usually calculated rather than directly measured. Clinicians estimate bicarbonate concentration using the Henderson-Hasselbalch equation, which relates bicarbonate to blood pH and carbon dioxide levels. The infographic also explains total carbon dioxide, or total CO2. Total CO2 is calculated using the equation. Total CO2 equals 0.23 multiplied by PCO2 plus bicarbonate. This means total CO2 reflects not only bicarbonate, but also dissolved carbon dioxide and carbonic acid present in the blood. Blood gas analyzers measure partial pressure of carbon dioxide, or PCO2, which is then used to estimate bicarbonate concentration. Key clinical note. One important point highlighted in this infographic is terminology. Although bicarbonate is sometimes casually referred to as total CO2, they are not exactly the same thing. Bicarbonate is only one component of total CO2, making accurate interpretation essential in acid-base disorders. Conclusion. To summarize, the kidneys play a vital role in maintaining acid-base homeostasis by carefully regulating bicarbonate. Most bicarbonate is filtered and then reabsorbed, especially in the proximal tubule. During acidosis, the kidneys conserve bicarbonate and excrete hydrogen ions to combat excess acidity. During alkalosis, they excrete bicarbonate to lower blood alkalinity. Finally, bicarbonate measurements in the laboratory are calculated using the Henderson-Hasselbalch equation, helping clinicians evaluate acid-base balance and kidney function. Understanding bicarbonate regulation is essential for diagnosing and managing conditions affecting the kidneys, lungs, and metabolic system. Welcome to this explanation of metabolic acidosis, a condition in which the blood pH falls below 7.35, making the body more acidic than normal. This infographic explains the major causes of metabolic acidosis, how bicarbonate buffering works, and the common medical conditions associated with decreased bicarbonate levels. Let's break it down step by step. What is metabolic acidosis? At the top of the infographic, we see the definition of metabolic acidosis. Metabolic acidosis occurs when the body accumulates too much acid or loses too much bicarbonate, resulting in a drop in blood pH. There are three major pathways that can lead to metabolic acidosis. First, excess acid production. Second, decreased acid excretion by the kidneys. And third, increased loss of bicarbonate, also known as HCO3. Any one or a combination of these mechanisms can lower blood pH and disturb normal body function. How bicarbonate buffers acid. In the center of the infographic, we see the body's bicarbonate buffering system, one of the most important defenses against acid buildup. Hydrogen ions, or H, combine with bicarbonate, written as HCO3, to form carbonic acid, or H2CO3. Carbonic acid is then converted into carbon dioxide and water. The carbon dioxide is removed through the lungs during breathing. This buffering system helps neutralize excess acid in the bloodstream. However, when acid levels become too high, bicarbonate is consumed faster than it can be replaced. As bicarbonate levels fall, blood becomes more acidic. Normally, serum bicarbonate levels range from about 24 to 30 milliequivalents per liter. Levels below 24 milliequivalents per liter may suggest metabolic acidosis. Condition 1. Renal failure and renal tubular acidosis. Let's begin with the first major cause, renal failure and renal tubular acidosis, often called RTA. The kidneys normally remove excess acid from the body by excreting hydrogen ions and regenerating bicarbonate. When kidney function declines, acid excretion decreases, causing hydrogen ions to accumulate in the bloodstream. This results in acid retention and reduced bicarbonate levels. The infographic also highlights two types of renal tubular acidosis. In proximal or type 2 RTA, the kidneys fail to properly reabsorb bicarbonate, causing bicarbonate to be lost in urine. In distal or type 1 RTA, the kidneys cannot effectively secrete hydrogen ions into urine. In both situations, the result is the same: hydrogen ion retention, bicarbonate depletion, and metabolic acidosis. Condition 2. Ketoacidosis. Next is ketoacidosis, a condition often associated with diabetes mellitus, starvation, or prolonged fasting. When the body lacks enough glucose for energy, it begins breaking down fats instead. Fat metabolism produces ketone bodies, including acetoacetate, beta-hydroxybutyrate, and acetone. These ketones are acidic. Initially, bicarbonate helps buffer the acid load. But when ketone production becomes excessive, bicarbonate stores become overwhelmed. As bicarbonate levels drop, metabolic acidosis develops. This process is especially important in diabetic ketoacidosis, a potentially life-threatening complication of diabetes. Condition 3. Lactic acidosis. The third major cause shown here is lactic acidosis. Lactic acidosis occurs when tissues do not receive enough oxygen. Examples include severe exercise, poor blood flow or hypoperfusion, and ischemia, where tissues are deprived of oxygen. Under low oxygen conditions, cells switch to anaerobic metabolism, producing pyruvic acid, which is converted into lactic acid. Lactic acid then dissociates into lactate and hydrogen ions. The extra hydrogen ions increase acidity, and bicarbonate is consumed trying to buffer the acid. As bicarbonate falls, metabolic acidosis worsens. Key concept: decreased bicarbonate. One major takeaway from this infographic is that low bicarbonate levels are a hallmark of metabolic acidosis. Whether the cause is kidney dysfunction, ketone accumulation, or lactic acid production, the common pathway is the same. Bicarbonate becomes depleted while acid levels rise. Conclusion. To summarize, metabolic acidosis is a condition where blood pH drops below 7.35 due to excess acid or bicarbonate loss. The body relies on the bicarbonate buffering system to neutralize acid, but severe acid buildup can overwhelm this defense. The infographic highlights three major causes: renal failure and renal tubular acidosis, ketoacidosis, and lactic acidosis. All of these conditions ultimately reduce bicarbonate levels and increase blood acidity. Recognizing the underlying cause is essential for proper diagnosis and treatment. Welcome to this explanation of metabolic alkalosis, a condition in which the body becomes excessively alkaline due to an increase in bicarbonate, or HCO3, or a loss of hydrogen ions. This infographic explores the major causes of metabolic alkalosis, the mechanisms behind elevated bicarbonate levels, and the role of the kidneys in restoring acid-base balance. Let's walk through it step by step. What is metabolic alkalosis? At the center of the infographic, we see the defining feature of metabolic alkalosis: elevated serum bicarbonate levels, typically greater than 30 milliequivalents per liter. Metabolic alkalosis develops when bicarbonate levels rise relative to hydrogen ions, making the blood more alkaline and increasing blood pH. The infographic highlights three major pathways that commonly lead to this condition: excessive alkali ingestion, vomiting and gastric acid loss, and primary hyperaldosteronism. Pathway 1. Excessive alkali ingestion. Let's begin with the first pathway: excessive alkali ingestion. This occurs when a person consumes large amounts of alkaline substances such as antacids or sodium bicarbonate, also known as baking soda. When excess bicarbonate enters the bloodstream, plasma bicarbonate concentration rises. Normally, healthy kidneys can remove extra bicarbonate through urine. However, if intake is excessive or kidney function is impaired, bicarbonate accumulates faster than it can be excreted. As bicarbonate increases, blood pH rises, contributing to metabolic alkalosis. Pathway 2: vomiting and loss of gastric acid. The second major cause shown here is vomiting. The stomach normally contains hydrochloric acid, or HCl, which is rich in hydrogen ions. When prolonged vomiting occurs, the body loses significant amounts of stomach acid. This means the body is effectively losing hydrogen ions, which are acids. As hydrogen ions decrease, bicarbonate levels become relatively higher in the blood. In other words, loss of acid leads to a relative increase in bicarbonate, shifting the body toward alkalosis. This is why persistent vomiting is a classic cause of metabolic alkalosis. Pathway 3: primary hyperaldosteronism. The third pathway involves primary hyperaldosteronism, a hormonal disorder characterized by excessive production of aldosterone. Aldosterone acts on the kidneys to increase sodium reabsorption. At the same time, it promotes the excretion of potassium and hydrogen ions into the urine. When too many hydrogen ions are lost, blood acidity decreases. This creates a relative excess of bicarbonate, pushing the body into metabolic alkalosis. The infographic emphasizes this relationship. Increased aldosterone leads to increased sodium reabsorption and increased hydrogen ion loss, resulting in alkalosis. Kidney response: nephron close-up. In the lower right corner, the infographic highlights the nephron, the kidney's functional unit. Under normal conditions, about 75% of bicarbonate is reabsorbed in the proximal tubule. Additional bicarbonate handling occurs in the thick ascending limb and collecting duct. The kidneys usually conserve bicarbonate because it is essential for buffering acid. However, when blood pH becomes too high, the kidneys can respond by excreting excess bicarbonate into urine to help restore balance. This mechanism acts as the body's natural defense against excessive alkalinity. Key concept: the key takeaway from this infographic is simple. Metabolic alkalosis occurs when bicarbonate increases relative to hydrogen ions. This can happen because of too much bicarbonate intake, loss of acid through vomiting, or hormonal changes that increase hydrogen ion excretion. In every case, the end result is the same: an elevated blood pH and increased serum bicarbonate concentration. Conclusion: to summarize, metabolic alkalosis is a condition marked by serum bicarbonate levels above 30 milliequivalents per liter, resulting in an increase in blood pH. The three major causes highlighted in this infographic are excessive alkali ingestion, vomiting with gastric acid loss, and primary hyperaldosteronism. Although the kidneys attempt to restore balance by excreting bicarbonate, severe or persistent causes may overwhelm these compensatory mechanisms. Understanding the underlying cause is essential for accurate diagnosis and proper treatment. Serum electrolyte measurement is one of the most commonly ordered laboratory tests in medicine. Electrolytes such as sodium, potassium, chloride, bicarbonate, and calcium play essential roles in maintaining fluid balance, nerve signaling, muscle contraction, and acid-base regulation. However, obtaining accurate electrolyte values depends not only on the patient's condition, but also on proper blood collection, handling, and laboratory processing. 1. Why do we measure electrolytes? Patient symptoms. Electrolyte testing is often ordered when patients present with symptoms such as nausea, weakness, confusion, swelling, or irregular heart rhythms. These symptoms may indicate underlying disturbances in potassium, sodium, calcium, or acid-base balance. For example, potassium abnormalities can trigger dangerous cardiac arrhythmias, while sodium disorders may affect brain function and consciousness. Monitoring medical conditions. Electrolyte levels are also monitored in chronic diseases. Patients with hypertension, heart failure, kidney disease, liver disease, or lung disorders frequently require routine electrolyte testing because these conditions directly affect fluid and electrolyte homeostasis. Kidney disease is especially important since the kidneys are the primary organs responsible for electrolyte regulation. Medication monitoring. Certain medications can significantly alter electrolyte levels. Diuretics may lower potassium or sodium, ACE inhibitors can increase potassium, and beta blockers may influence potassium movement between cells. For this reason, clinicians regularly monitor laboratory values to prevent complications from treatment. 2. Blood sample collection and handling. Correct specimen collection. Accurate electrolyte testing begins with proper specimen collection. First, contamination with intravenous fluids must be avoided. Blood should never be drawn near an active for infusion site because saline or medication contamination can falsely alter electrolyte results. Choosing the correct tube. Selecting the correct anticoagulant is equally important. Lithium heparin tubes are commonly used for electrolyte testing because they preserve sample integrity. In contrast, sodium heparin can artificially alter sodium measurements, and tubes containing potassium additives must be avoided when testing potassium levels. Avoiding hemolysis. One of the most common laboratory errors is hemolysis, the rupture of red blood cells during blood collection. When red blood cells break apart, intracellular potassium and other electrolytes leak into the plasma. This can produce falsely elevated potassium levels, a phenomenon called pseudohyperkalemia. To reduce this risk, blood should be collected gently and transported carefully. Separation and processing. After collection, prompt centrifugation is essential. Delays in separating serum or plasma from blood cells allow electrolytes, especially potassium and chloride, to shift between cells and plasma. This may result in inaccurate laboratory values. Immediate processing helps preserve true electrolyte concentrations. 3. Blood gas panel considerations. Some electrolytes, particularly bicarbonate and ionized calcium, are highly sensitive to sample handling. In blood gas analysis, samples should be tested within 30 minutes and must remain free of air bubbles. Exposure to air changes carbon dioxide levels, which can alter pH. And because bicarbonate and ionized calcium depend heavily on pH, improper handling can significantly distort results. Ionized calcium and bicarbonate. Bicarbonate is closely linked to acid-base balance and is influenced by carbon dioxide levels. Similarly, ionized calcium, the biologically active form of calcium, is affected by blood pH. For this reason, strict collection and handling procedures are necessary to ensure accurate interpretation. 4. Key workflow steps. The ideal workflow for electrolyte measurement follows several essential steps. First, collect blood carefully. Second, select the appropriate collection tube. Third, avoid hemolysis during handling. Fourth, centrifuge the sample promptly. And finally, proceed with laboratory analysis. Following these best practices ensures reliable results and helps clinicians make safe, informed medical decisions. Conclusion. In summary, serum electrolyte measurement is more than a routine blood test. It is a critical diagnostic tool. Accurate results depend on both clinical understanding and proper specimen handling. By minimizing contamination, avoiding hemolysis, and processing samples correctly, healthcare providers can ensure that laboratory values truly reflect the patient's physiological condition. Because in medicine, even small laboratory errors can lead to major. Some common measuring electrodes are listed below. 1. An IC for Na plus utilizes a membrane permeable to Na. 2. An IC for K plus utilizes a valinomycin membrane. 3. A Cl. IC utilizes an ammonium salt anion exchange membrane. 4. An IC for ICA, Ca2+, utilizes a liquid chelator. 5. An IC for total CO2, HCO3, utilizes a Severinghaus electrode. Methods for measuring electrolytes, especially Na, may be direct or indirect. 1. Direct methods. the sample is not diluted prior to analysis. 2. Indirect methods. The sample is diluted prior to analysis. Samples that have excess protein or samples that have very high lipid concentrations will displace more plasma water than specimens with normal lipid and protein concentrations. When these samples are diluted prior to analysis, a significant amount of Na is excluded from the measurement. This is referred to as the electrolyte exclusion effect. It results in a falsely low value for Na and other electrolytes. Ideally, patient samples with abnormally high lipid and protein concentrations should be analyzed by direct IC to confirm the indirect IC results. Assessment checks for validity. The following checks should always be used to assess the validity of patient test results prior to reporting. Na and CL values should correlate. If Na is high, CL will usually be high. If Na is low, CL will usually be low. If this is not the case, investigate for testing errors. Correlate total CO2, TCO2, and CL values. There is usually an inverse correlation. If TCO2 is high, CL will usually be low. If TCO2 is low, CL will usually be high. If this is not the case, investigate for testing errors. Low and negative anion gap numbers should be rare. They could be an indication of testing error. Normal ranges. Each laboratory must determine its own reference ranges. However, the reference ranges for electrolytes don't tend to differ significantly from laboratory to laboratory. Typical reference ranges for electrolytes are shown below. Blood gas quiz. Test your knowledge. Let us start.
A patient presents with primary hyperaldosteronism. Serum sodium and potassium tests are ordered. Which of the following results would be the most consistent in this condition? Please select the single best answer. 1. Low sodium normal potassium. 2. Low sodium high potassium. 3. High sodium low potassium. 4. Normal sodium low potassium. Answer. 3. High sodium low potassium. Primary hyperaldosteronism is characterized by the adrenal cortex's excess production of aldosterone. Aldosterone secretion facilitates sodium reabsorption and potassium secretion, resulting in a high serum sodium concentration and a low serum potassium concentration. Which alternative methodology can be used for electrolyte determination that is not susceptible to interference caused by hyperlipidemic samples? Please select the single best answer. 1. Direct potentiometry. 2. Turbidimetry. 3. Absorbance. 4. Fluorescence. Answer. 1. Direct potentiometry. Ion-selective electrodes utilizing direct potentiometry are not susceptible to the solvent exclusion effect caused by hyperlipidemic or hyperproteinemic samples. Using this direct methodology, the sample is presented to the sodium and potassium ion-selective electrodes without dilution. The concentrations of sodium and potassium are directly proportional to the concentration of these ions in the plasma water, and not the total diluted volume. As in indirect potentiometry, direct potentiometric methods are used in most blood gas analyzers and in some other analyzers. Turbidimetry, absorbance, and fluorescence are all vulnerable to interferences caused by hyperlipidemic samples. The following results were obtained on a non-hemolyzed plasma sample, collected in a green top tube containing lithium heparin as an anticoagulant. The patient is a 35-year-old outpatient who had blood tests as part of a routine annual physical. The sample was centrifuged 30 minutes after collection. The patient also had a lavender top tube containing EDTA collected for a complete blood count, which was completely normal. The patient has no known medical condition that would account for the increased potassium concentration. Which of the following may have caused this increase? Please select the single best answer. 1. The sample was centrifuged too soon after collection. 2. Lithium heparin causes an increase in potassium. 3. The lavender top tube containing EDTA may have been collected before the tube used for electrolyte testing. 4. The blood tube may not have been inverted to mix the sample after collection. Answer: 3. The lavender top tube containing EDTA may have been collected before the tube used for electrolyte testing. If the tube containing EDTA was collected before the tube used for potassium testing, and blood mixed with the EDTA carried over into the green top tube, potassium may be falsely elevated because EDTA contains potassium salts. The other possibilities that are listed would not have caused a false increase in potassium. A blood sample for potassium testing should be centrifuged as soon as possible after collection, and at least within 2 hours of collection. This was the correct procedure. A blood collection tube containing lithium heparin is acceptable when the plasma will be used for potassium testing. Lithium heparin would not cause an increase in the potassium result. Failure to mix the blood tube after collection would not affect the potassium result. An arterial blood gas syringe drawn on the patient in the emergency department was loosely capped, put in a biohazard bag, and delivered to the clinical laboratory using the hospital's pneumatic tube system. Which of the following would occur as a result of loose capping of the blood gas syringe? Please select the single best answer. 1. A falsely decreased O2. 2. A falsely increased CO2. 3. A falsely increased O2. 4. No change in O2 or CO2. Answer: 3. A falsely increased O2. Air contamination is a recurrent source of pre-analytical error that can cause significant inaccuracy in reported blood gas values. Under normal conditions, room air has a higher PO2 than arterial PO2. If air is not removed from samples immediately or otherwise comes into contact with the specimen prior to analysis, the blood in the syringe will move toward equilibration with the air due to Henry's law of gases, causing a falsely increased level of O2, and PCO2 would fall. Which electrolyte has the primary function of maintaining acid-base balance? Please select the single best answer. 1. Sodium. 2. Potassium. 3. Chloride. 4. Bicarbonate. Answer: 4. Bicarbonate. Bicarbonate is a major buffer responsible for maintaining acid-base balance. It is the main non-protein buffering agent found in blood. Sodium, potassium, and chloride may alter due to acid-base imbalance, but none of them function to maintain acid-base balance. What is the main form of carbon dioxide, CO2, in the blood, normally accounting for more than 90% of the total CO2? Please select the single best answer. 1. Carbonic acid. 2. Dissolved CO2. 3. Bicarbonate. 4. Hemoglobin. Answer: 3. Bicarbonate. The main form of CO2 in the blood is bicarbonate. Because bicarbonate composes the largest fraction of total CO2, total CO2 measurement is indicative of bicarbonate measurement. Carbonic acid and dissolved CO2 are also part of the total CO2 in the body, but together, they normally account for only about 10% of the total CO2. While hemoglobin does act as a buffer, it is not a source of CO2. Which electrolyte has the largest influence on normal distribution of water and regulating the osmotic pressure in the extracellular fluid, ECF? Please select the single best answer. 1. Sodium. 2. Potassium. 3. Bicarbonate. 4. Chloride. Answer: 1. Sodium. Sodium is the main player in maintaining the normal distribution of water and regulating the osmotic pressure in the ECF. Potassium is important for electrical impulse transmission, particularly in the heart and skeletal muscle. Bicarbonate is the main buffering agent of the blood. It is responsible for maintaining acid-base balance. Which of the following statements is not true concerning chloride, Cl? Please select the single best answer. 1. It can shift from the extracellular to the intracellular fluid of red blood cells. 2. Excretion and reabsorption of cell parallels that of HCO3-. 3. It is the major anion of the extracellular fluid. 4. It enters the plasma in exchange for HCO3-. Answer. 2. Excretion and reabsorption of cell parallels that of HCO3-. Excretion and reabsorption of cell parallels that of Na+, not HCO3-. It can shift from the extracellular to the intracellular fluid, and from the intracellular to the extracellular fluid of red blood cells in exchange for HCO3, to maintain electrical neutrality. This is referred to as the chloride shift. Cl is the major anion of the extracellular fluid.